As you know, we've been focusing on adolescents this year and have done quite a bit. We've had quite a few discussions on various aspects of behavior and secondary mental health problems in adolescents with fetal alcohol spectrum disorders. We're going to take a slightly different route today and address something that is really quite contentious and varies in how well states are addressing this issue from one area of the country to the other. We're going to be talking about adolescents with fetal alcohol spectrum disorders who are in the child welfare system. And our speaker today is somebody I'm very happy to welcome and to introduce all of you to. Sid Gardner is the president of Children and Family Futures in California. He's going to conduct the webinar today. Sid is the author of one of the chapters for our new book, Moment to Moment Perspectives on Fetal Alcohol Spectrum Disorders in Adolescents. And he's written a chapter on the child welfare system. And I thought it would be very appropriate to include him in this webinar series also. So Sid, I'm not going to take up your time. I'll turn it over to you. And welcome, and they're all yours.
Thank you very much, Ira. Welcome to all of you. Good morning to those of you on the Pacific Coast, as I am, and good afternoon to the rest of you. Looking forward very much to this presentation and also to your questions. We really do want to try to engage with you. Many of you are affected by this as professionals, as parents, sometimes in dual roles, and we'd love to have your feedback. As was made clear during the presentation, we'll have time, I think, at the end to address those questions. I am the president of Children and Family Futures. It's a nonprofit organization based in Orange County, California. We operate with federal funding and state and local funding, also as the National Center on Substance Abuse and Child Welfare. And as the name of the organization suggests, that's an organization that tries to work in the juncture between the child welfare and the drug and alcohol system. I should also make clear, in the interest of full disclosure, that my wife and I were foster and are adoptive parents of two children who came to us through the child welfare system. They passed more or less successfully through adolescence and are now 21 and 23. But as you'll recognize, a few of the comments here are drawn both from our professional experience with child welfare and treatment agencies around the country and also from our personal experience. It's important to understand as we start that we're talking about a fairly substantial segment of the child welfare system. And I want to say, in looking at that system at the outset, that though, as Ira suggested, child welfare agencies range from reasonably responsive to the issues of FASD to a good deal less so. But child welfare agencies, as many of you know, at the state and local level, carry a sizable burden these days. The resources are often not adequate to the challenges. The numbers have gone down overall of those in out-of-home care, but it's fairly clear from data that many of you are familiar with that what that's meant is that some of the harder to serve cases, parents and children alike, are those that are represented in those smaller numbers. So when we talk about adolescents in the child welfare system, we're talking about nearly a third, a sizable number nationally in those states where expansion of the foster care coverage has meant that 19 and 20-year-olds have been taken into the caseload. That also needs to be taken into account. These youth are subject to risk factors that we'll be talking about. In one study, those factors were estimated to be as much as 10 to 15 times higher than those in the general population. They are children who've been in the foster care system a long time. They are children who in some cases will stay in the foster care system until they age out at 18 or older without adoption or any other kind of permanent placement having been made. And that aging out phenomenon has increased over the past 11 years. So it's a sizable group of children and youth. Those that have been in the foster care system for quite some time have been affected by it, and we want to turn to that particular issue. FASD can worsen the impact of foster care, can create a need for foster care, but at the same time, living in foster care itself can worsen the impact of FASD. As earlier segments in this set of presentations and other chapters in the book that I mentioned moment to moment have made clear impulse control and decision making have been affected by FASD effects in the brain in many of the youth that we're talking about. But if you place those youth with those brain effects in a controlled environment with rigid rules, that lack of impulse control and the decision-making skills being weak can be accentuated, worsened by the foster care situation itself. When it's unstructured, when the supervision is uneven, those children and youth may have even less support in decision-making. They don't learn what they might learn in an environment that's more like a home, about school, career, relationships. They find themselves in repeated difficulty, and in part that can be a result of foster care as well as a reason for those children ending up in foster care in the first place. So it's important to not blame the child welfare system alone, but also to understand that foster care, ranging as it does from adequate, pretty good, first rate, on down on the other end of the spectrum to not at all good, and in some ways causing further harm. When it's an FASD youth that we're talking about, those effects can be substantial. In understanding these children, we've looked at a number of studies that make clear that they have aged into and may age out of the system because they're least likely to be adopted. They may have bounced around in multiple placements. Their behavioral problems will have affected them in school, both in terms of the behavior in the classroom and their ability to learn. Their learning disabilities can be important factors in school systems, in effect throwing up their hands, and the dialogue, as we'll talk about in a bit, between the school systems and the child welfare systems about these youth can sometimes be quite strained. They're much more likely to abuse drugs and alcohol. Their histories of trauma because of co-occurring domestic violence, substance abuse, and mental illness in their parents may mean that they're carrying their own mental illness problems on top of the issues of FASD. And they're more likely, particularly as they age out, but in some cases while they're still in foster care, to have children prematurely and to have children later on outside marriage. So these are the issues that these youth are carrying while they're in the child welfare system, and the risk factors that child welfare agencies and foster and adoptive parents have to deal with. So how do child welfare systems respond to this array of risk factors and these challenges? As a number of the chapters in Ira's book and the earlier presentations that some of you have been part of have made clear, the diagnosis of FASD is not something that the child welfare system at norm does especially well. Some of you are very familiar with CAPTA, Child Abuse Prevention and Treatment Act, which has two important requirements with respect to FASD. First, that when birth effects are detected of illegal drugs or FASD conditions, there is a required referral to Child Protective Service Agency, not for purpose of prosecuting parents or removing children, but for purposes of connecting those parents with treatment. A second requirement is that for all substantiated child welfare cases under the age of 3, those must be referred to the Part C agencies, IDEA, agencies that handle early intervention for developmental assessment. A standard question that is asked when working with states and localities around the country by our organization and others is, how many CAPTA referrals did you have this year? I'm sorry to say that in a number of states, the child welfare agencies don't have an answer to that. The federal government does not aggregate those statistics on an annual basis across the states. So the CAPTA referrals, a very well-intentioned law and amendments in 2010 by the Congress, does not result in us knowing a great deal about those conditions at birth and during the first 3 years of life. That means that when we're talking about adolescents, they may never have been identified as FASD affected in the child welfare system. They may have labels on them put by school systems, by child welfare agencies, by psychologists that they've been referred to, labels including attention deficit disorder, oppositional behavior. They may be labeled as being on the autistic spectrum, bipolar disorders. because these labels are not developed in most cases within the child welfare system, but by referrals to practitioners who may not themselves understand the details of FASD diagnosis, and may have a number of children on waiting lists that have been referred to them by the child welfare system. So child welfare systems respond at first based on what they know about FASD. If that has not been diagnosed, then that condition is invisible, and other labels and other conditions and other problems may be what the child welfare system pays most attention to. That can be a sizable problem if you're trying to get help for these children. That help often resides outside the child welfare system. One of the most important challenges child welfare agencies face in working with these children, and in fact in working with their entire caseload, is to recognize that child welfare agencies cannot by themselves achieve the outcomes that they're mandated to achieve. They are what the public administration types call open systems, in that their problems come from outside and many of the solutions that they need help with come from outside. These other agencies, schools, universities, maternal and child health, early childhood care and education agencies, hospitals, health providers, mental health providers, obstetricians, pediatricians, developmental disabilities agencies, and others all have an important role in both prevention and intervention. But a child welfare agency may find it very difficult to establish relations. They may make referrals to these agencies, but that's not the same thing as having an ongoing relationship in which both sets of agencies are getting reciprocal benefits, in which they understand who's being sent and what they're expecting will happen as a result of a referral, in which there's a detailed protocol and reporting back on the outcomes in the agency to which an adolescent may have been referred. That's hard to work through. That's the guts of collaboration, and doing that across more than a dozen agencies, actually, as will be needed by some of these adolescents, is a tremendous challenge to ask of child welfare agencies. But the critical step, the first step, as people in the recovery business sometimes say, is recognizing that you're powerless, or at least that you need help, and to seek out these other agencies and not try to solve the problems within the walls of the child welfare system itself. So those referrals, that collaboration, those interagency protocols and relationships become critical, especially so for these adolescents who may, in many cases, have been in the system for several years already. It's also important to understand that birth and foster and adoptive parents all have roles that have to do with causes, roles that have to do with efforts to alleviate those causes and to set these adolescents on positive paths. When these youth are adopted out or end up in foster care, it's important for all three sets of parents, ideally, to understand the difference between normal adolescent rebellion and FASD affected behavior. I can assure you that sometimes in trying to explain to friends with adolescents some of the issues that my wife and I have dealt with, I get a quizzical look, and finally somebody says, well, they're adolescents, right? And so it is an age of rebellion. It is an age in which some of the FASD behaviors closely resemble behaviors of, quote, normal adolescents, and understanding that difference is important. It's also important to understand the challenge that faces child welfare agencies and those agencies that work with child welfare agencies in trying to enhance the process of adoption. Explaining brain disease and neurodevelopmental effects and FASD consequences without frightening foster and adoptive parents is an important balancing act. In some cases, the child welfare agencies may not even know the details of prenatal exposure. They may have been given a referral of a 3-year-old. Again, the CAPTA diagnosis at birth or in early childhood may not have been a part of the child welfare record, and the child welfare agency may not ever bring up the issues of FASD. It's important, therefore, to convey the message to parents that Ira's chapters and work by him and the other people in the FASD field have emphasized, and that is that nurture can make a tremendous difference in dealing with the organic effects of prenatal exposure. Parents need to understand that, need to know that you can't erase the effects of FASD with the world's greatest parenting, but that nurture is tremendously important. Children who are adopted or in foster placements also have a very frustrating to parents, to adoptive parents, tendency to, as they get into adolescence, to want to seek out their birth parents, regardless of the original history of trauma, abuse, neglect. There is a sort of idealized desire on the part of some, not all, but some of these youth to want to reconnect, to want to check out how their parents are doing, to hope, particularly if they've been subject to discipline and constraints in their foster or adoptive parent families, to hope that the birth families will be more lenient. Adolescents seek lenient rather than strong discipline, and that sometimes leads back to the path of the birth parent. For a foster or adoptive parent who may have given decades of their lives to raising these children, that can be very frustrating. But it's a very powerful tendency to reconnect. Sometimes when these youth age out of foster care, they then seek back to the connections with their birth parents, trying to make things right, trying to see if they're doing better, or just trying to get in touch with somebody who was a part of their life at one point. So parents have to deal with those tendencies, both understanding that they may not have been told by the Child Welfare Agency in the first place, that the children, the youth, may be seeking out their birth parents, and they also need to deal with the bewildering array of agencies and processes that are very hard for professionals to understand, much less foster and adoptive parents. At one point during the first 6 months of my wife's and my experience with our then foster children, we were counting the number of agencies we dealt with, and after 6 months and going past 50 agencies, we decided to stop counting because it wasn't helping our overall attitudes toward the process. But we were dealing with IEPs, the school's process. Later we got to know a little bit about the delinquency system, about reimbursement from Medicaid, about mental health, how in different states the Medicaid system works differently. At one point we had a child who was in 3 different states' Medicaid systems because she'd moved from one residential placement to another. Hopefully that's not the typical case, but I can assure you that foster and adoptive parents are not fully equipped when they're briefed in a week or so of training to become foster parents, or in the screening for adoptive parents. They're not fully briefed on what the FASD conditions may demand of them in terms of working with other agencies. Foster and adoptive parents sometimes have to become their own case managers, because the case manager who's designated by the agency may know well how to work with Medicaid, but may not understand how to work with mental health, or may understand how to work with some agencies that are in the school system, but when the child's been removed and placed in a continuation school or a special private placement, that may be much more difficult. So all those examples of the challenges make clear, I hope, what we're asking of foster and adoptive parents. Recent legislation has tried to address the help that foster and adoptive parents need, both in training and in ongoing case management support to deal with the issues that I've mentioned. And while we're hopeful that some of that legislation and some of those pilot projects will help some parents who are dealing with these issues, it's not at this point at a scale where the full range of parents who are involved in these issues are going to benefit. Schools, as I've mentioned, are a critical resource, and NTI Upstream, Ira's agency, and that of his colleagues, has done a lot of work working with different states. The good news is that some states are in much stronger condition to respond to the needs of these youth. The other news is that some states are not responding and need a good deal of oversight, may not be responding to these issues at all under the label of FASD. Some states have worked with the federal categories of special education in which FASD does not turn up, And so youth get classified in their junior high and high school years. These adolescents get classified as falling into one of these other areas, sometimes very loosely labeled other health impairments, which doesn't tell you a great deal about what the school or the parent needs to work with that adolescent. Schools can play a critical role, but it's unlikely in most schools, in most states, most of the time, that FASD conditions will be explicitly what's being addressed. It may be more likely that autism or bipolar or ADD or other issues will be how the school has classified the student, understanding some of the problems that the adolescent is facing, but not really understanding the full range of FASD effects and the critical issues of emotional control, cognitive effects, and impulse control. For schools not to understand those runs the risk, of course, that the youth who are removed, sometimes appropriately, sometimes inappropriately, and placed in special education will then bounce out of those placements and into continuation schools or special schools, schools run by the delinquency and probation system, which may compound the issues of anger and trauma as a youth moves through those different systems. What works on the positive side, there are some positive programs that have helped parents and agencies in the child welfare system and beyond deal with FASD youth. As I've already mentioned, schools need to know how to train their staff and how to get access to diagnostic resources so that they aren't slapping a convenient label on youth without understanding the underlying conditions that may be affecting them. Child welfare agencies, in some cases, do a very good job with independent living programs funded with federal funding in part and therefore mandated, but some of those do not address substance abuse prevention issues of the kind that youth who are highly susceptible to their own substance abuse problems based on FASD risk factors. So that may not be in the curriculum, and it can be important when independent living programs do address that to explain to FASD youth that those are some of the challenges that they deal with. College attendance programs were launched in a number of different parts of the country. Here in California, the Guardian Scholar models, with the reference that we've included here, are an excellent example, but when national organizations interested in these issues convene groups from around the country, 30 or more states had programs that provided support to foster youth for higher education. The extent to which those addressed FASD conditions, the challenges of learning, the challenges of simply getting to class on time, of organizing a schedule, of working with counselors who may not themselves understand a great deal about FASD. It's good that there are programs that focus on foster youth. It'd be better if there were programs that focused on foster youth affected by FASD. That's a rare commodity in terms of professional counseling, but those resources are there, and there is a growing recognition that those programs can't start in high school. You can't go to juniors who are in middle class constructs just beginning to think about college in their junior year. In some cases, that has to go all the way back to K-8, or those youth will be transferred into non-college prep classes, and by the time they're junior, it's too late for them to even qualify to enter in community college, much less four-year institutions. So the extent to which that is part of the secondary and elementary school system, and the extent to which those are recognized, the FASD issues in particular, can have a great effect on higher education options. Peer models and supportive housing programs, the Jim Casey Youth Opportunities Initiative, have been focused on foster youth aging out of the system. Again, that's a resource that's not focused as heavily on FASD conditions that may work with these youth without those diagnostic tools having been brought to bear, but it is a tool that is available to the foster youth themselves. And finally, parents may benefit from peer programs, sharing their experiences in coping with FASD. Some of you in this webinar may have been part of parent support programs, as we have, in which so-called wraparound services or parent support programs have come to your homes in some cases, and attempted to work with foster and adoptive parents in helping them. It's important to note that even though there may be a team from an agency, a child welfare agency, or even an agency specializing in adoption, there's no guarantee that members of that team, who often, unfortunately, haven't had foster or adoptive experience, though they sometimes do, it's important to note that members of that team themselves may not be familiar with FASD issues. The parent by this time may be the expert in the room, even though a team has been sent out to help the parent. And sometimes parents talking with other parents can be a tremendous source of knowledgeable support. There are a number of online websites and support groups through Facebook and other social networks that have enabled parents who are facing these issues to share stories. I've been in a number of national conferences where talking with fellow professionals, sooner or later the issue that they're dealing with, a child who's got some of these issues, comes up, and the conversation moves to a new level in which it's possible to share rewards and frustrations, the challenges and joys of all this in a totally different way than two professionals can do. So peer programs, formal and informal, social networked, and those operated through child welfare agencies can make an important difference. In terms of parents themselves, these are more practical tips, clinical to be sure, but practical as well. The first challenge in some ways in beginning the role as a foster or adoptive parent of a child who's come through the child welfare system is to find out what you can. If the agency doesn't know, there may be supportive family members. There may be a cousin, there may be a brother or sister, there may be a grandparent who at some point attempted to become the caretaker, who may be more objective about the FASD causes and effects and may be able to provide you agency that the child welfare agency doesn't provide. It's also okay to ask the child welfare agency to go back and try to find that information through their own files. There may be things in case files that didn't get into the formal data system. As we've gone back through case files, in some cases we find much more detailed references to substance exposure, both prenatal and postnatal, than is always recorded. States record substance abuse as a factor in foster care removals in a range from 0%, one state doesn't report the issue at all, that is, they don't report that any of their foster care removals were affected by substance abuse by parents, and some states report as high as 65%. Depending on where you are, that data may not be in the system, but it may be in the case file, and it's appropriate to ask child welfare agencies, what can you tell me about Johnny? Can you look back at the case file? Can you have one of the case managers go back? There may be some resistance to that, but it's an appropriate query for a foster or adoptive parent. It's also important in talking to the youth themselves to talk about other disabilities. Many parents, particularly as they age into their roles and their former adolescents become young adults, are wearing glasses or hearing aids or other supportive machinery that helps deal with their own disabilities. It's important to acknowledge that a lot of people have disabilities, visible and invisible, and to look at neurodevelopmental effects in that context, rather than making an FASD youth feel as though he or she has a unique disability that no one else can understand or talk about. As I've already said, it's important to encourage school districts to understand FASD issues and not to slap the easy labels on these youth. It will take special training to understand FASD. We've had conversations with special education and classroom teachers as well as counselors in which it was fairly clear that FASD issues were just not in their repertoire. And it was necessary to suggest gently, politely, with professional respect, that they needed to know a bit more than they understood about those issues in order to respond and help us respond to the needs of our children. So that dialogue with school districts as well as the dialogue with child welfare agencies may be essential in parenting adolescents. It's also important to watch for the opportunities with the youth to encourage deliberation. Stop and think may seem like a very simplistic slogan. In our family, it became useful to reduce that to SAT as a cautionary note to my son at critical points in his development, which he took seriously and recognized was a way that he could pause, as impulse control issues did not always help him pause and think about what will happen if I do this, what will happen if I don't go to class, what will happen if I push this kid on the classroom after he said something to me. Reinforcing that at home and in school is an important parenting quality. It's also important to watch for the things that kids are good at. Adolescents are at a point where they're trying a lot of things, some bad, some good. They're also learning what they're good at, recognizing that children who may have been affected by a loss in their fine motor skills may still have extraordinary gross motor skills. My son is a very fast runner, and that enabled him to interact with a whole group of athletes and others outside the arena that he was headed toward in terms of special education, and developed a whole new set of friends. He developed confidence in his own ability. He won some prizes, worked hard to get them, and that was a way of saying you have some abilities as well as some disabilities, to go looking for those things that they're good at, for recognizing that youth who may have cognitive problems may also have a rather remarkable ability to memorize some facts that they're interested in, and that FASD is not a uniform blanking out of the capacity to memorize, that sometimes something of interest to an adolescent may be an area where they really want to spend some time and go into depth in ways that can show their ability and give them some self-confidence in their ability to memorize things. And it's also in a time when we're all walking around with memory aids, with our calendars and our notes to each other, and all kinds of other mechanical aids in our pocket, or now on our wrists, or built into our glasses, that there are many ways to provide first simple and then more complicated memory aids and task focus assistance in mechanical ways, and to help a youth gain the confidence that they can manage those smartphones or tablets or whatever else they're going to have access to, not only for schoolwork, but also to help them remember the things that they may not be able to easily recall, given their disabilities. And providing them with those aids is a very important way of giving them some skills that are built into some of that equipment that may make up for some of the issues that they face with FASD. Finally, I want to pick up a theme, tragic to remember. That's the back of Robin Williams, who in the movie Good Will Hunting played the role of a psychologist working with a youth, played by Matt Damon, who had been terribly abused as a child. And what he says in this counseling session repeatedly is, "It's not your fault. It's not your fault." He says that over and over in a very moving segment that we pictured here in this clip from that movie. It's sad to think of Robin Williams being gone, but it's important to remember that that message is an important one that we convey to youth who are trying to figure out who to blame, how to blame themselves, how to take the measure of personal responsibility they have to take for getting out of the predicaments they sometimes get themselves in. But it seemed to us that that was an important way to frame the issue, and that particular moment in that movie with two extraordinary actors captured it very well. So that concludes my formal presentation. These sources, I'll take a moment to orient you to some of them. AFCARS is a data system known well to you in the child welfare system. It's the Federal Foster Care and Adoption Data System. It's available online so that you can see for your state just how well they capture the impact of parental substance abuse in removal to foster care. And knowing whether you're one of the states that does that well or not at all well is important. The Journal of Pediatric sources and an article that Ira has forthcoming, as well as the one that he published in 2010, are excellent sources that are behind some of the materials that we cited in this. The Orangewood Foundation is a foundation here in Orange County, and their website goes into detail about the Guardian Scholars Program, the program that prepares foster youth for college by working with high school counselors, and as I said, going back in some cases to middle school, junior high levels to make sure that these youth get into the right courses And I mentioned the Jim Casey Youth Opportunities Initiative. That's a part of the family of Casey Foundation organizations. Gary Stangler, the executive director there, is an extraordinary professional, and they've done a lot of work on adolescent brain as it relates to foster care.